So hello, here we are. Welcome to Tanya and Claire, who are the two doctors that I have rustled together to talk about the effect of, or what we know about the effect of long COVID on the hormonal system, particularly the female hormonal system, because no surprises there. I have had most questions, or in fact, all questions in from women who want to know what's happening to our bodies. Is it the menopause? Is it COVID only? Is it both things? How can we tell the difference? What I will say before I even come to you guys and have you introduce yourself is we don't know a lot right now. You know, the research is being started, but it hasn't been completed and it will take some time. So my wonderful doctors here are going to help us just kind of explore around the edges of some of the questions that we've gathered from our beautiful Facebook group and see if we can come up with some red flag moments, like, you know, definitely do go and have this followed up at the GP, or maybe just sit this one out for a little bit and wait and be reassured by some of the stuff that we know already. So Tanya, why don't I come to you first? Why don't you tell us a little bit about your journey, because not only are you a GP, you've also had long COVID yourself. So tell us a little bit about that.
Yes, hello, hi. So I'm Tanya Patrick, I'm a GP in London, and I've actually been off work for the last year after getting COVID in March. So I got a fairly mild case of COVID and then in March, and then unfortunately had a couple of relapses and fell ill with what we now know as long COVID in July. So I've actually been off work since then and have had quite significant fatigue, like a lot of us, brain fog, migraines, which we knew, really unable to walk very far for quite a long time, for a good few months. And actually, thanks to Susie, I diagnosed myself with POTS, which I didn't know much about before getting it myself. So Susie was somebody who I came across on one of the Facebook groups with long COVID, and she was an absolute lifesaver. She kind of introduced me to yoga, having never really tried yoga before, and has really helped me to keep up exercise when I was feeling really low, and also stop the deconditioning. So it was Susie's advice to get a tracker watch to stop myself walking too far. And it was only after getting a watch that I realized my heart rate was going crazy, and I actually have POTS. So thank you, Susie.
Wow,
I'm not sure I've ever told you that.
No, you didn't. So that's great. Wow. Okay. Well, we know so much more about POTS now than we ever knew before in our lives, because of, you know, the work we've been doing with the group, and also the stuff that we've learned from Dr. Boone Lim and Melanie Danny. So, you know, I think we probably all in some ways now experts on POTS. So thanks, Tanya. It's great to have you on board. And Claire, you are not someone, luckily for you, who is dealing with a COVID recovery yourself. Tell us a little bit about you.
Yeah, so no, luckily and touch wood, I have not had long COVID. I'm a GP based in London, and I had COVID too last year, probably about the same time as Tanya, probably March time, and recovered as far as I can tell reasonably well. And I come to this really from an angle of having a special interest in the perimenopause and the menopause, and really trying to make women's post-reproductive lives as great as possible, and thinking of it as, you know, the second chapter and the best chapter that we could possibly make it. And so I'm quite interested in thinking about hormones and how possibly long COVID could influence that, but also making sure that women are kept fully informed in terms of perimenopause and the menopause. So that's where I'm coming from.
Great. And just tell us, you're also doing a little bit alongside Louise Newson, aren't you? So
yeah, so I'm lucky enough to start to do some clinics with Newson Health, which is great, because it just means that we can try and reach as many women as possible. And obviously most people will know Louise as being a great advocate for the menopause, and she's done a lot of amazing work trying to really emphasize the importance of good hormonal therapy in the perimenopause and menopause, and just trying to treat women really thinking about them as deficiency in hormones, rather than, you know, this is just a bit of cream or gel that we can apply to make you feel better, but really thinking about it as a hormone deficiency state. So yeah, that's what I've been doing recently.
Great. Well, I know that, you know, in our wonderful Facebook group, we have had many group discussions around what's happening to me, what's going on. So we've collected a lot of questions, which I have here in front of me. And I'm just going to start working through the list, okay? So I know you've got them there in front of you, but I'll just read it out anyway. So question number 1, here we go. A lot of us are confused about what's happening to us. If we were to look at the average age of the female with long COVID, it's somewhere between 30 and 50. And obviously there's people going above that and there's people going below those ages. But if we looked at an average, it was around that age. What are the changes to expect in normal time? So if you took COVID out of the equation, what does perimenopause and menopause look like? Because so many people have perhaps only just really started to think, is this menopause? At the same time as going through the, oh my God, I've got long COVID. So what would be normal for someone without long COVID to be experiencing through the perimenopause stage? And what would the range of experiences look like before we add in the complication of, and is this long COVID as well? Why don't I come to you, Claire, first with that one, because you sound like you're going to be able to hit us off with that one.
Yeah, so certainly around the age of middle to late 40s, I would expect most women to be perimenopausal. And all that means is that it's the run up, the time frame or the transition, if you like, of when your periods might stop. So below that age, I'd be wanting to think about other things, you know, not necessarily the menopause or the perimenopause, but around the middle of, you know, 42s above. And obviously this is a fairly fluid number, because it's not a one size fits all. I'd be expecting most women of that sort of age to be perimenopausal. And that transition is really tricky because it's not set in stone. It can last a number of years. And it can be very confusing because you can have one or a number of symptoms or you know, just a handful of very sort of foggy symptoms that don't necessarily collectively form a diagnosis. So you could have one week and one another week, and you might be going to your GP, and it's difficult to put them all together at times. And that transition, like I said, could last anywhere from sort of 2 to 8 years. The average in the UK is about 5 years, but around the age of 50, 51, we'd expect for your periods to stop. And that is technically when you reach the menopause, so a year and a day after your last period. And actually that is really just a day in time. So you kind of have this transition period of being perimenopausal for a number of years, potentially a day when you go, oh, I look back, I haven't had a period for a year, I'm menopausal. And then you have your post-menopausal phase. So really there's a kind of a 3-stage process, with that middle phase being a day essentially. And it's something that is not talked about very much, particularly because, you know, we're very good at talking about periods, and we're very good about talking about antenatal care and postnatal care, yet we don't really tell anybody about the perimenopause or the menopause.
So give us an example. What, I mean, I'm 49 and I don't know what symptoms, you know, because I've had long COVID or COVID in recovery for, you know, a year and a half now. What symptoms should I be experiencing as a perimenopausal woman?
It's an interesting question, because some women won't experience anything at all. Right. But the symptoms of the perimenopause are vast. So you could be having commonly a change in your cycle, so a change in your periods. And obviously we'll talk about that a bit more later in terms of COVID. But yeah, so a change in your cycles, you could have hot flushes, but sort of only around 25% of women probably won't have a hot flush. So you can't rely on that as a symptom of the perimenopause. And then you have things like brain fog, loss of concentration, memory problems, word finding difficulties, low libido, vaginal dryness. You know, it's top to toe. So thinking about hair loss, tinnitus, dry eyes, dry skin, joint pains, palpitations. The list is really endless. And you can see why in isolation, one of those symptoms, it's difficult to diagnose, but collectively, and if you look at a woman very holistically, you can see how actually if you put all those together, you could probably say, yeah, you're perimenopausal. I mean, that's obviously ruling other things out too. But
Sure. The thing that strikes me about that list when you read it out, and it always makes me want to laugh out loud, it's like you're describing long COVID as well. Which is why I can totally understand why so many women are going, well, is this long COVID or have I been tripped into quite a strong set of perimenopausal symptoms? Or are they both happening? Is it happening because it's, which one is the trigger, the chicken or the egg here? Which is fascinating, isn't it? Because is the same hormonal change happening that would be happening in perimenopause because of long COVID? And is it happening earlier for some women because they've had that COVID infection? And I think we all know we don't actually know the answers definitively to that yet, but there's definitely more and more information coming out. Women are noticing a change, irrespective necessarily of sort of where they're at sometimes. Okay, so that's fascinating. We've definitely got this kind of a great spectrum of symptoms, and I know as you've said, that there's a lot more than that, and I know some women who've had some really quite extreme symptoms in the run up to their actual menopause, ranging from kind of terrible headaches and migraines and almost I've known someone who got sort of a paralysis that was then linked back to her perimenopausal symptoms. Tanya, is there anything that you can add to this that you've come across in your own practice over the years where you've gone, wow, that's also perimenopausal?
Well, I think what I was going to add perhaps is more around why we think maybe so many women are getting long COVID as opposed to men. And I know that a few people have done a talk on this already, but I think it's important to just discuss that. So we know that estrogen is quite protective. It plays a protective role in our immune system. So it's really important for sexual development and reproduction, but it's also really important for our immune system. And it regulates a lot of our immune cells. So it regulates cells like the neutrophils and the macrophages and the natural killer cells. So when we have low levels of estrogen, the lifespan of those immune cells can become much lower. And we also know that estrogen is quite good at down-regulating the cytokine storm. So when you have low levels of estrogen, you're much more likely to get that cytokine storm, which is one of the theories behind long COVID. So there's a few sort of theories there as to why women around the age of the menopause or in their 40s and 50s are getting more long COVID than men, probably because of low levels of estrogen at that time. And the other theory that I think probably has been discussed quite a lot is that women are much more prone to getting autoimmune conditions than men. And so although we don't yet quite know whether long COVID is an autoimmune condition, there's a lot of I think there's a lot of research being done into that, and there's a lot of theory that it probably is, or a lot of conditions within it are most likely autoimmune. So even POTS, for example, there's a very high chance that a significant number of people with POTS there's an autoimmune cause there. So I think there's a couple of reasons why women in their 40s and 50s are getting a lot of women are getting long COVID.
Yeah, great. I think it's a really valid point. And it is something that, again, we're going to just keep saying it throughout this whole interview. Research is being done, but we don't know enough yet. It's too early. It is just too early for us to know, isn't it? We're only just beginning to put the pieces of the puzzle on the table, never mind put them together. Okay, right. So let's move on. We're going to go to question 2. Having long COVID does disrupt and deregulate the autonomic nervous system, which is a main system which is the main system which runs many aspects of the body, or one of the main systems, should I say. The wording of this question is a little bit dodgy. The endocrine and hormonal system is part of this. So is it likely that long COVID would dysregulate our hormones? And which hormones might create the biggest impact? Estrogen, progesterone, testosterone? So this was, I think, a particular question that came in from the group. So there's lots of bits of that question. Who wants to go first with that one?
I can have a go, I don't mind. Yeah. So I think initially we thought COVID-19 was a respiratory disease, and then quite quickly I think we realized that it wasn't just respiratory. It affected an awful lot of organs, or almost any organ in the body. We were seeing it, affecting the heart, the gut, the brain, as well as the lungs. So I think, and then with time we worked out how COVID-19 actually entered the body and what the process there was. And so we now know that it enters the cells through a receptor called the ACE2 receptor. And there are ACE2 receptors on many cells in our body, including the cells of the uterus, the ovaries, the placenta, all the sex organs. So we know that COVID can and probably does enter the ovaries and enter the uterus. And so in that respect, it's very likely to cause some degree of ovarian dysfunction if that happens. And so that in itself will then potentially cause menstrual irregularities and fluctuating or disordered hormone levels. And then another theory, which is it makes complete sense, is that if the body's under a lot of stress, so if the body's got acute COVID or has got a more chronic picture of long COVID, there's a lot of stress, the body's in that kind of fight or flight response for a long period of time. So the body's kind of pumping out cortisol to try and fight off this disease, and it's in this high sort of state of stress for a long time. And we know that over time, stress can have an impact on our hormone levels and can cause reduced estrogen, reduced progesterone, reduced testosterone. There is a theory that because all of these hormones kind of come from the same pathway, so the steroid hormones are all derived from cholesterol originally, and so when the body is making a lot of cortisol, it's almost stealing away some of the energy that's being used to make the estrogen or the progesterone. And that's a theory. Some people don't agree with that theory, but it kind of makes sense that if the body's putting all its energy into making cortisol to fight off this illness or this disease, then the other hormones will get a bad deal, and there'll be much less of them around. So I think that there are a couple of reasons how the hormone levels can be affected.
Fascinating. I think personally, having had COVID myself, I was really aware that my body was so focused on fighting the virus and the impact of it that I really felt other parts of my body being neglected. And I think that's one of the reasons why people's hair falls out after this kind of, it just goes, okay, we have no energy for hair production can go. Let's focus over here. But, at the time it's terrifying because you're thinking, well, how much of my hair is going to go? And I know people who've lost all of their hair, so the body definitely goes into a kind of prioritization mode, doesn't it?
Mm-hmm.
Amazing. Okay, thanks. That was a fantastic response to that. Very, very detailed. I'm going to read this next bit out here. So if a dysregulated autonomic nervous system can cause an imbalance in the endocrine system, what might we see? Might we see the period speeding up, periods not stopping over a couple of months, very heavy clots, bleeding in the middle of the month, ovulation time, peeing a lot, pelvic pain and pressure, debilitating PMT, uncontrollable crying, post-menopausal bleeding? There's a lot that people have sort of flagged up as this is what's happening for me. So I was going to call you by your sister's name there, Claire. Claire, let me come back to you. Because this is where we start to kind of try and separate out, if it's even possible, long COVID versus menopause.
Yeah, I think that's the key question is are we trying to separate these two out in this group of women, or should we be thinking about it more as a collection of symptoms? And I think some of those questions, actually, what's really striking is the sort of psychological symptoms there. So things like tearfulness, PMT, and I know PMT is very physiological as well, but there's an element of mental health difficulties there, as well as the physiological problems. And we know that excellent explanation by Tanya earlier, we know that there's a lot of research that's being done into COVID and its effect on the brain, and particularly on the hypothalamus. And the hypothalamus is a bit of our control center. And we know that it has a lot of input in regulating our hormones and regulating our mood. And that also in turn can help sort of regulate our cycles. And so, if there is an effect, and we know that COVID can attack the brain, and we know that if it's getting into those control centers, is it perhaps disrupting that downward regulation? So all of our hormone cycles, there's an upregulation and a downregulation, and our hormones aren't only produced in our ovaries, and they come from our brains. And so perhaps is there an imbalance there that COVID is causing, alongside a potential early perimenopause or a natural perimenopause? And I don't think we could separate that at this time, because there's still so much work to be done. But I also don't see how we could separate it going forward, because I think if we've had COVID and you've had long COVID, your body's still in that stress response. It's still fighting. So you're still having quite a lot of high stress hormones, cortisol, which like we mentioned, what does your body need to do to function and what does it not need? Particularly in times of stress, we know, like we've said, hormones, periods, out the window. Don't need that. Don't need the reproduction part of our lives. We need just to be able to function, metabolically. And so I think all of those are quite possible, potentially, and all of those are quite possible both with long COVID and the perimenopause.
It's interesting, isn't it? And so many women have experienced some kind of disruption. So I know, Tanya, you just mentioned to me that, in our discussion prior to me pressing record, that you'd had a disruption to your cycle. Just tell us a little bit about that. How did it show up for you?
Yeah, so it didn't happen actually for quite a while. It perhaps only happened maybe 6 or 8 months after getting COVID. And it was only for 2 or 3 cycles where I had a very short cycle. So normally I'm fairly regular every 28 days. And then suddenly I think I had a period maybe after 14 days and then again after 21 days. And I thought, oh, this is strange. And then I saw lots of people reporting similar changes to their cycle. So I figured it was probably a COVID thing. And then it went back to normal actually. So it didn't last too long. What I was going to say though, along these symptoms, so I think it's likely that long COVID can cause almost anything to happen to your cycle. So it can become shorter, longer, heavier, lighter. And whether that's perhaps because you're perimenopausal, we won't know. But it could be entirely due to COVID. If it is COVID and not menopause, and so you're younger perhaps than, so say you're in your 30s or early 40s, it's likely that the periods will just go back to normal, and then we'll know it wasn't a menopausal problem. Whereas if they don't, and you're more towards the, as Claire says, the mid 40s or the late 40s, then it's likely that you're entering the perimenopause and the cycle may not go back to normal. And it's common as you go into the perimenopause for you to get change in your periods, heavier, lighter, more frequent as well. But I think it's really important that there are a few things we should mention that if you do have, you should go and see your GP. So
yes, please.
If you are having post-menopausal bleeding, for example, so that's bleeding, so after you've had the menopause, which is 12 months after your last period, if you then have, so it's more than 12 months after your last period, if you then start to have a period or a bleed, you do need to go and see your GP because that needs to be investigated. Similarly, if you're having bleeding after sex, that's abnormal and you need to see your GP about that. And if you're having very unusual, heavy, persistent bleeding that's lasting more than 3 months or very frequent bleeding at any age, I think you do need to see your GP. Give it 3 months, see if it settles down, but if not, then do go and see your GP.
Great. And I think that's what you just said there, just give it a little bit of time and see if it settles. And, in the way that you spoke about the disruption that you had from COVID to your own cycle, it did settle down after a couple of months. And I would also say my experience around about the same time as well. So I'd had dead regular periods. And then around the 6-month period post-COVID, I noticed a disruption to my cycle. I think, again, they became very short. So I had a couple of periods sort of every 14 days and then one very long bleed that lasted for about 30 to 40 days. And then it all just sort of settled back down again. And I've been quite surprised because I'm 49 and part of me was thinking, oh, well, here we go. This is me, at the beginning to kind of head into that more constantly sort of dysregulated period pattern. But I've gone back to a very dead regular 26-day cycle again. So I think, I am seeing quite a lot of women going through that sort of a period of quite intense and at times quite scary disruption, especially if you've had fairly regular cycles for years and years. You get used to that, right? Something comes along like COVID and you go, what's just happened? Is this scary? Should I be worried? And, of course, check it out. But also know that there's plenty of stories out there of people who go, oh, actually, this is all just settled down again. Once my autonomic nervous system and the endocrine system, all the systems have gone, oh, it's okay. It's okay. We can resume some sense of normality again. Great. Okay. Let me have a little look here. So, and actually this kind of feeds into what we've just been saying. So I've got a question here that I'm going to read out from someone. I'd just like to know the how and why COVID affects the menstrual cycle so negatively. And I think we've been touching that one already. So here's a kind of example. My periods are now every 21 days, very heavy with clots. I bleed for 10 days, much longer than I used to, have 10 days between the next period, during which time I experience debilitating PMT, feeling so low and intense and crying uncontrollably for 2 whole days some months. I'm even getting a mini period in between and spotting around ovulation time. Her doctor has suggested tranexamic acid to reduce the bleeding as it's draining me so much, but I'm worried that it's only a short-term solution and might make my periods heavier when I stop taking it. So in some ways, we need to look at that in reflection of what we've just been saying around it might be a short period of time that there's a disruption for. But Claire, why don't I come to you and, what would you say to this woman if she presented to you?
I think there's a lot in that question, isn't there? I think the key thing is establishing, what her cycles were doing before and seeing how they've changed for her, because some women do have transitions in their cycles where they have, sort of changes, not necessarily related to COVID, but certainly sometimes related to COVID, but other things as well. So thinking about what else is going on, thinking about her age and how old she is, and would a hormone profile be beneficial here? But certainly as her GP, I think tranexamic acid is a good idea to give her some respite in her bleeding. It's certainly not necessarily a long-term solution, but it's not going to make her periods heavier when she stops it, because I think her periods probably would have been heavy already. So it's just helping her at that point in time. I think there's a lot of, I'd want to know about blood tests, maybe even, like we mentioned earlier, thinking about other causes for her periods to be heavy, thinking about thyroid potentially, but certainly thinking about some hormone profiles to check that that's okay if she's of an age where that would be appropriate. But it sounds like she's having a really tough time, and she's not alone. I mean, there's many women who've had COVID and long COVID and are having similar problems. I think it's really important, like we said before, to think about monitoring it and giving it time. Sometimes these do settle. Sometimes these changes in cycles do settle. And if they're still not settling, that's when I want to probably do some more investigations.
Yeah. And I think, when I read that question out, I can really feel the worry and the upset, and she's living with this moment to moment, and we can read it as a statement on a piece of paper, but this is this person's life, and it's clearly a much bigger experience for her than her average menstrual period would be. And so, absolutely keeping an eye on it and making sure that she's perhaps pushing to get the care that she wants from the doctor, and not taking kind of like, oh, well, take this and come back in 6 months, just to keep on it and getting that kind of reassurance that there's nothing untoward going on.
I think, can I add that, as Claire said, there's more information we need on that a little bit. So it'd be helpful to know how old she was and whether she was taking contraception and whether she's had any investigations done already. But say she is in her, mid 40s, early or late 40s, and she's not on contraception. I think it probably, and it is persisting, so it's not just a transient problem, it's persisting beyond 3 or 4 months, say, then it definitely is worth investigating with bloods and maybe even a scan. But then there are other things that can be done to help, maybe that might offer a bit more help than tranexamic acid. So in the form of hormonal therapy treatment, whether that's a Mirena coil, which could stop her irregular bleeding and may or may not help with the hormonal fluctuations that are causing the PMS. Having the Mirena coil will often stop your periods, but quite often you still do get the hormonal fluctuations that cause the PMS. So for some people, they notice an improvement, but some don't. But it might be worth trying. Or or if she's even able to take the combined contraceptive pill, that might be something that can regulate her periods, offer her some help with some improvement from the PMS, but also help the bleeding. But it all really depends on her age, her risk factors, what else she's tried. So there are definitely things to try in addition to tranexamic acid that might be able to help her.
Great. Well, that's really great to know. And one of the things that I just thought there was, I'm aware that quite a few women have posted similar questions into the group and into the main Facebook group, and also have been experimenting with the mini pill and the coil and various things. So it might be worth this specific case, and anyone that's anyone that's hearing this and going, oh, that sounds a bit like me, just to kind of seek advice from those people who've also done that, and on what route have they gone down, and has it made a difference, and just start to use that kind of peer information that we have access to in the Facebook group, because there's so many women on this journey, we might as well learn with each other as we go. So if this is you listening, ask, ooh, what have you done? And has it helped? And get to know a little bit more. Okay. We're going to look at the vaccine now, and I think we're going to cover this one only in a tiny way, but how and why might women's periods be affected by the vaccine, as many report changes to their cycles as a result of having had the vaccine? So Tanya, why don't I come to you first of all on this one? What are your thoughts on this?
So I think in that we know COVID can change our hormones and affect our cycle, then it follows then that the COVID vaccine may have similar effects on the ovaries, on the cycle, on the menstrual cycle and the hormones. So I think theoretically it could. I don't think we know yet why or for how long. I do understand that there's a study going on by Tim Spector, I guess through the Zoe app at King's. So they are doing a study into this onto the effect of the vaccine on people's menstrual cycle, but I think we don't actually know much at this point. And I would hope that similarly to COVID, the vaccine is probably only giving you a transient effect on your cycle, and that the effect is not it won't be a long-lived problem. So I'd hope it will just go back to normal fairly quickly. And if it doesn't, again, perhaps worth speaking to the GP about that.
Yeah, great. Let me just ask, has either of you two had any? You've both had the vaccine, right?
Yeah.
Did you notice any difference to your cycles? I'm just curious.
No, I didn't actually. But like we said, anecdotally, there are women who have noticed a transient change. And like we said at the beginning, whilst we don't have the evidence and the research is not there, the more information we gather about women's changing in cycles post-COVID or post-vaccine, the better. It's really interesting actually, because a lot of women have said or reported to me that their periods have changed, whether heavier or lighter. But personally, mine didn't.
No, mine didn't.
No. Well, I only just had my second vaccine last week, so watch this space. Post first one, I was fine, I think. Okay, so here's another question. I am a 49-year-old woman relapsing around my period. So I think this is a really common thing. So I'm Tanya, you're nodding. I noticed quite early on that, after my initial COVID infection, as I start to head towards my period, I was getting more and more ill with my COVID symptoms. And then I'd kind of come out the other side of my period, and I'd kind of come back up again and find a balance. And that I realized was a pattern. And so many women notice that relapse around the hormonal changes in their system. And when you kind of make that realization en masse, it's a real aha moment, especially because no one had really identified it, because it was new. No one was talking about it. We're talking about it a lot now, but at the time last year, it was like, is anyone else noticing that as they get their period, they are really sick with COVID? Yes, said 10,000 women. What would a GP test for or look for to understand whether this is long COVID or perimenopause? So I think we've already covered some of this, but I think it's good to talk about that relapse around period. What would a red flag for a doctor to do more tests, as we know there is no single test for the menopause? What would a red flag be? So yeah, what are your red flags, just top of your head? Claire, why don't we come to you?
Yeah, so I think what we mentioned before, so particularly, you know, if you're menopausal and you've not had a period for 12 months, so for a woman that's having symptoms or feeling worse towards, you know, what we've got to remember is that when you're menopausal and you haven't had a period for 12 months, you may still have very low levels of hormones. And around your typical mid-cycle, you may be feeling worse, particularly if you've had COVID. So it's thinking about what's going on in your cycle. But red flags would be things like post-menopausal bleeding, or particularly for this woman, a change to her bleeding pattern, bleeding after sex, bleeding sort of in between your typical cycle. So, you know, if you're having a 28 to 38 day cycle, you know, or 32 day cycle, give or take a few days, if you're having a bleeding in between that, or bleeding after sex, I'd want to investigate. But certainly around the age of 49, she's right, you know, there isn't one test that we would do to say, yes, you're definitely perimenopausal, or yes, this is related to long COVID. And that's the tricky thing, is that it probably is a bit of both here.
Yeah. I mean, it sort of has to be, right? We know that the COVID hormonal relationship is an interesting one. And we know by the age of 49, as a 49-year-old woman, there are hormonal changes going on with or without COVID. So in a way, I think what we're trying to say is don't try and extract them both from each other. Because they're kind of in relationship with each other. The two things are happening symbiotically in the body. Great, which leads us on to the question, and I know this is asked a lot in the Facebook group, is there a way to check your hormone levels through the NHS? Because as you've already discussed with me prior to this chat, most of you wouldn't be sending people to get their bloods done unless there was something particularly untoward that was showing up for you. Is that right? Tanya, why don't I come to you first?
Yeah, so the NICE guidelines state that if a woman is over 45 and having menopausal symptoms, that we can diagnose her as perimenopausal through the clinical picture alone. So in that she's having perimenopausal symptoms, and so including irregular periods, hot flushes, mood changes, insomnia, you know, joint pains. And so we don't need to, and we shouldn't do bloods in those women. But if you are under 45 and you start to have any of those symptoms, then we would do bloods, and that's to pick up anyone who's having an early or premature menopause. And the reason for that is that the bloods are actually really unreliable in diagnosing the menopause. So somebody might be going through the perimenopause, they might have irregular periods, they might have some of the changes that in mood and the insomnia, but yet their bloods may be normal. And so in that case, it doesn't really help us, you know. Does it mean we don't treat them? Does it mean we don't give them HRT? And right. I think therefore it just isn't helpful. And because we know that the hormones are very different at different stages in the cycle, they're just a very unreliable test for the menopause. But I think if you're under 45, that is the time when it is appropriate to do bloods. Saying that, if you're over, you know, if you're 45 or older and you're having symptoms of fatigue, or I think like the lady said previously in her question, you know, you can still have some bloods done, and it might be worth still, you know, doing some other bloods. So looking at your full blood count, making sure you're not anemic, looking at your thyroid function, looking at things like vitamin levels, B12 and folate, and just looking at other causes of fatigue or irregular periods. And so it's still worth having that chat with the doctor, because I think blood still may be appropriate.
Oh, interesting. So just take it as a kind of like health MOT test rather than I'm checking to see if I've got the menopause coming around the corner. Okay, great. That's really worth knowing, because I think a lot of people, you know, we're in a kind of phase, especially because we've been so focused on our health. If you're in that kind of long COVID group, you want to know, you just want to know stuff. You know, you're at a point where you're just like, okay, I want to learn as much about what's happening to me so I can help myself in the best way possible. And if there's a test that I can take that gives me some information that allows me to take that supplement and not that supplement, I'd like to take that test. But what I'm hearing you say there is actually those tests are really not that reliable. We're just going to look at what shows up, what's actually appearing for you symptom-wise. How is your experience of that? And let's work with that, because that's going to give us much more of a sensible picture than perhaps some slightly all over the place blood results. Okay, yeah, that's really worth knowing.
And, you know, I think in that age group, if you're having symptoms of long COVID and you're having symptoms of the perimenopause and we don't know which is which, then it might be appropriate to try, a course of HRT to see if that helps your symptoms and give it, a number of months on that to see if you're feeling better. And if you do, great, and we'd probably be wanting people to be on transdermal estrogen, like the natural form of estrogen, and then either a progestogen through the Mirena coil or maybe as a tablet.
Well, I think that's going to lead us on to a slightly bigger conversation around this, because someone on question 8, I'm going to look at here. Would you, as a doctor, experiment with putting yourself on a hormone balancer such as the Mirena coil? If you were experiencing these symptoms, but you were still having your periods, what would you do? So actually, Tanya, let me come back to you, and then Claire, let's hear from you around your kind of more clinical experience.
So personally, myself, I did actually change. I had the copper coil previously to this, and I changed it to the Mirena coil, and that's probably mainly because I was getting really bad migraines, and a lot of them were menstrual migraines. So I tried the Mirena coil to stop my periods to see if they helped my menstrual migraines, and they haven't completely got rid of them, because, as I said earlier, with the Mirena coil, although it often stops ovulation in some women and it stops your period, you can still get those fluctuating levels of estrogen and progesterone that cause the symptoms of either migraine or long COVID. But it's potentially worth a go. You may find it helps. It's certainly, if you're having really irregular bleeding and we're not worried that there's a serious cause, then the Mirena coil can then help a lot with that. It may help the sort of perimenstrual symptoms, but it may not, and you don't really know until you try it, actually.
Yeah. So Claire, let's come to you and hear your thoughts on that, and we can open this up one, not just talking about the Mirena coil, but maybe the mini pill and any other kind of HRT things that people are beginning to experiment with in the treatment of long COVID, perimenopause, menopause. Let's hear from you.
Yeah, so again, absolutely everything Tanya's just said, really. I mean, I think the Mirena coil is great to try to regulate your cycles a bit, and it does that by thinning the lining of the womb directly. And so in most women, it stops the bleed completely. And if you're having very erratic periods, or if you're having very heavy periods with clots, it can be really nice just to not have a period. And I think that is great in itself, if that's something that is particularly troubling for a woman. If you're having these very, very heavy cycles, the Mirena coil is a really good option, and we use it regularly for that fact alone. So in women with heavy periods not related to anything else, it's a great go-to. So I think it's definitely worth a trial if you're having some issues with your periods around COVID and the perimenopause. It's also a fabulous progesterone for the progesterone component of your HRT. So it's a really good part of the HRT. So we can use it for up to 5 years as the progesterone component of our HRT. And like we said earlier, using a transdermal estrogen on top of that, which is a gel or a patch or even a spray these days, can be really, really helpful too. So I certainly think that the Mirena coil is really helpful. A lot of women worry about using the Mirena coil, and perhaps if they've had a history of quite bad PMT or symptoms, or if they've had previously bad effects on the progesterone-only pill or the combined pill, they worry that maybe using the Mirena coil might have a similar effect. And for most women, obviously, again, it's not a one size fits all, but for most women, they find that using the Mirena coil doesn't give them those systemic body effects that maybe taking a tablet would, because the hormone is really only absorbed very locally within the womb, and it doesn't get absorbed elsewhere in the body. And I'd say that's the case for the majority of women. Some women who are particularly progesterone intolerant find that they might have a few side effects, but on the whole, it's really well tolerated. I think there's been quite a lot of bad press recently about coil insertions, hasn't there? And it being the most painful experience in a woman's life, aside from giving birth. And I think that's really sad, because done correctly with some simple painkillers before insertion and after insertion. It should be well tolerated. It's not a nice procedure to have, but it's certainly not awful, and it shouldn't be deeply uncomfortable and horrendous. I think there's one woman describing it as the most horrific thing that she'd ever had done, and I felt really sad for her, because that's an awful experience to have had, and it shouldn't be like that. So I'd say, don't be scared by those stories. I think that go and see your GP or health professional, go and see your local sexual health clinic if that's something you want to have done, because it can be inserted relatively painlessly.
Perhaps ask how many times that person has performed that procedure. Are you an expert at this, I'd say? Because if you're not, then I'll come back another day.
I mean, the interesting thing about that is that you do have to be certified to insert a coil.
I would like to think so.
There is a very strict process. I haven't got that certification. I don't insert coils, but you have to be a certified coil inserter.
Good.
To do that. So you have to have been.
Is there a certificate on the wall that should be there? I mean, that's something worth looking for, right?
Yeah, no one's going to do it unless they've been approved.
Okay.
I think, yeah.
I mean, I've fitted hundreds of coils, and I would say that everyone's different. So some people find it really painful. They do, and certainly people who've not had children, they're more likely to find it painful.
Yeah.
But the majority, it's a very short-lived pain. And so most people, tolerate it really well. And certainly after you've had children, it's a doddle. It's not probably not painful. I mean, I've had loads of coils myself, and the last few I didn't even feel them go in. So it gets better. It gets better. Don't give up.
It gets better.
And also, if you've had a bad experience of one time, it doesn't mean the next time is going to be a bad experience, because sometimes the body responds differently. So it's if you want one, definitely go for it.
I think we've all got a sort of probably a memory of having one of those smear tests that you go, oh, that was the worst thing ever. And then the next one you go, oh my God, that was totally different. So, I understand how these things can be completely different time to time again. Okay, so let's just ask you, Claire, about the mini pill then, because I know some women are saying, oh, I'm going to go on the mini pill. I mean, this is more of a discussion for a younger woman, I think, that I've seen in the group, and it might not be, but quite a few women are trying that out just to help them regulate what's going on. So that leads me to a question which is slightly different. So I'm going to double layer this one. So how does HRT act on a regular body, and how might it act on a body that's already dysregulated? So what we're asking is, how are these hormones helping to regulate a body that's already dysregulated? Does it work in the same way as on a regular body?
And it's a really good question. I think really we don't know until you've tried it.
Yeah.
I think, around the time of the perimenopause and menopause, I think our body is already undergoing quite a lot of stress. So I think our stress hormones are rife at that point. And so there's also that added layer of is cortisol also affecting our mood and the symptoms? And then you add COVID and the fluctuations potentially in the hormones brought on by that. And I think we just don't know enough about it yet. So I think HRT on the whole is actually it's good to think about it as regulating your cycles or regulating your hormone levels. And certainly if we're thinking about the perimenopause and menopause as being a hormone deficiency, what we're doing is trying to add back what your body would have produced naturally anyway. So we're not trying to sort of give you too much. We're just trying to keep you at a level that you would have been at had you been producing estrogen and progesterone naturally anyway. So I think it's more about thinking of it as a replacement and trying to regulate your natural levels a bit more, rather than thinking of it as is it going to sort of over-regulate or under-regulate my natural cycles?
Right.
We're aiming for it to give you back something rather than cause more problems.
And my assumption, and I've never taken any, is that you would start on a low dose of anything that you're working to rebalance, and then just watch for what happens in the body. And if someone says, oh no, that's made me feel worse, or then you kind of maybe tone something down. So it's like you're tinkering with the levels. There isn't just like a one size fits all HRT, is there?
Absolutely. So, we know that younger women, and certainly women who go through a premature menopause, often need very, very high levels of estrogen. So we wouldn't think about starting low, well, we might, but often we don't think about starting low doses of estrogen in that type of age group. Typically, we'd always want to give you the lowest dose possible, because that's just really good practice, and that's what our nice guidance suggests. But around the perimenopause with fluctuating levels, you probably need a really good going dose. And that, again, like you say, varies in different women. So what suits me won't suit you, and the preparation that suits me won't suit you necessarily. And so it is exactly that. It's tinkering with the dose. And so we'd aim to give a woman a dose for sort of at least 3 months, really, a bit like the pill, a bit like you probably heard doctors say, try this for 3 months and see how you get on. Because it does take that amount of time for your body to get naturally established on a preparation before we start tinkering with doses.
Okay. And with the mini pill in the younger woman, is that something that someone of my age would be thinking about, or would you be looking more at HRT rather than going for just, the mini pill? Because in a way that's, is it that I would be too old, not in that category, to kind of be experimenting with that kind of treatment?
So no, I don't think so. So certainly the mini pill can be used in an older woman, absolutely. We wouldn't use it as HRT in any way, because it's not a strong enough progesterone to protect the lining of the womb. So if we're thinking about regulating hormones, I think HRT probably would be better in an older woman. But progesterone, certainly as a contraceptive in a younger woman, is worth a try if that's something that she wants to give a go. I'm not sure if it would obviously butt in here if you feel free to butt in, but sometimes progesterone can cause some systemic upset. So sometimes it can make you feel a bit PMT, it can make you have a bit of breast tenderness and bloating. So in some women, actually makes them feel worse rather than better. So I think it's always worth kind of having that discussion with your health professional, just to say, well, this is something potentially I'm considering. Certainly if you're considering it from a contraceptive point of view, it's great, but also being aware, being very mindful that it can cause some side effects like those I've mentioned, but worth a go, and certainly worth a 3-month trial. I'm not sure I'd probably use it as a mood stabilizer in someone that's going through this sort of symptom.
Sound like it from what you're saying. No.
I don't think it's the best first thing to try. I think, thinking about things a bit more holistically might be a better first approach.
Tanya, anything you want to add to that?
Yeah, no, I agree. It's a good contraception. It can help with stopping periods, but in some women they get quite persistent irregular bleeding on it. And as Claire says, some people do get changes to their mood or skin or weight, and so that it isn't, I wouldn't go to it as a first line at this, for this problem, but it can be a really good contraception. But that if you don't need contraception, I probably wouldn't go there.
Yeah, great. Okay, fine. Okay, let me have a little look here. Where are we at? Oh, interesting. I don't know if either of you have any thoughts around navigating histamine levels in estrogen with HRT. Do you know anything about the histamine discussion? Do you know much about MCAS? Tanya, you've probably been exposed to more of the conversations around MCAS through kind of being part of the Facebook group for a while.
So I didn't know much about estrogen and MCAS. I did look it up and do a bit of research, and I don't think there's an awful lot of evidence out there. But from what I could find, and I don't have MCAS myself. I did wonder at one point, but I don't have any symptoms really of histamine intolerance. So, but I think from what I could understand, that estrogen, high levels of estrogen can cause mast cell destabilization, and therefore a higher level of histamine release. Okay. And so in women perhaps who are quite estrogen dominant, have quite high levels of estrogen, they may have more unstable mast cells. So I think it's all about the levels of hormone and the balance between the progesterone and the estrogen. And if things are in balance, then that's optimal for mast cells. But if things get out of balance, I understand that that's when then you can maybe run into problems. So I think progesterone is more protective of mast cells and reduces levels of histamine. But estrogen, if their levels are too high, I think can cause higher levels of histamine.
Oh, that's really interesting to know. Claire, you're nodding away down there. Are you seeing any of this in clinic at all? People discussing their kind of
So it's
histamine?
really interesting because a lot of women have, well, not a lot of women, some women have what we call histamine intolerance, which is the dreaded histamine intolerance when we're thinking about HRT, because like Tanya said, we're not quite sure whether or not it's estrogen or if it's progesterone or if it's the balance or if it's more it's such an unknown. And then we know that sort of some women are very progesterone intolerant. They tolerate their estrogen really well. And we know that, perhaps adding the progesterone, which they need if they've got a womb still, perhaps that is what's causing the sort of histamine overload. We're just not sure. Again, it's all about evidence, and like we said, but like Tanya said, about the mast cells and how to stabilize the mast cells, and if that's hormone imbalance, and it's a very delicate balance in some women, and whether or not we just tip them over the edge slightly with estrogen or with progesterone. Again, I'm afraid I don't know enough about it, and I think there's still a lot of evidence that we need to look at and research that needs to be done.
Well, I think more and more women are definitely learning about their tolerance to histamine and, their sort of their body's own natural hypersensitivity to it, if that's something they're beginning to identify with. And we're definitely learning a lot about MCAS from Dr. Tina Pierce and the work that she's doing on MCAS and long COVID. So it's definitely going to be more and more, I think, part of women's discussion when they come into that kind of menopause conversation in clinics around and about. So we're going to finish now on fertility, because obviously, we're talking about a group of women, some of whom will still be focused on, is this going to affect my ability to conceive? And what should I be thinking about? How can I be looking after myself? So first part of the question here, should we be worried about fertility if we are still 12 months plus relapsing around menstruation? And actually, I would like to add to that, is someone's body at a point where they're able to be thinking about, is my body well enough to be growing a child right now if I'm still having quite a strong experience of some of my symptoms? So Claire, why don't we come to you with that one first?
So I'd say that, first of all, what we should be thinking about in any woman that's thinking of fertility and conceiving and conception, whether it's sort of short-term goal or long-term, is making sure they're as healthy as possible. They're doing everything they possibly can from a lifestyle point of view to ensure that their body is as healthy as possible. So that's your basics. That's your diet, your exercise, your sleep, your stress levels, all of the things that we know can influence our hormones, and all of the things that we can directly influence ourselves. So we can change these things. These are modifiable factors. I think that we don't know enough about fertility in COVID and long COVID. But certainly if you're trying to conceive and you're having trouble conceiving with a diagnosis of long COVID, or you think you've got long COVID, do go and see your GP, because depending on where you are, there are certain criteria that we follow in terms of looking at your fertility within the NHS. Okay. And that will depend on your age, it will depend on a number of things, but it's certainly a discussion that I would encourage any woman to have with a GP, just to start that discussion, because too often we have that discussion a bit late in the day and sort of further along down the line, and starting that discussion early. So thinking about lifestyle modifiable factors that you can have a direct influence on, thinking about supplements, I would say making sure you're getting enough folic acid, enough vitamin D, enough calcium in your diet. There's a really great website that I signpost a lot of my women to called the Calcium Calculator. And it's a bit of a tedious website, I'll be fair, because you have to input everything you've eaten for sort of a week. And then it calculates, or probably sometimes a bit longer depending on your age, but it calculates sort of what what levels of calcium you're getting in your diet. And it's always really surprising when I do it to myself, because I'm like, oh, I think I've probably reached the limit of my calcium, and I'm so way down on what I should be taking. So it's thinking about sort of making sure you're getting enough calcium and vitamin D so that your body is as healthy as possible to start growing that child, because we know that growing a child really takes it out of you. And so making sure you're well enough from that point of view. But those are the things. I wouldn't necessarily suggest any blood tests or hormone profiles before that. I would make sure that you're doing everything you can be doing. And like I said, further down the line, if there's a problem, then perhaps at that point, thinking about bloods.
From a yoga teacher's perspective, one of the things that I would chip into this conversation, and I think just before we come to you, Tanya, is, what I'm hearing is there's going to be worry and anxiety around this. And if you're sitting on that worry and that anxiety, that will show up in your body. And actually, one of the things that we know is, COVID will disrupt the systems of the body. And actually what we can do with gentle yoga, relaxation, calming, meditation, breathing, is bring some of those systems back into a really nice place of status quo. And there's work that she can do to kind of get her body prepared. That's not just about taking supplements. It's about going, okay, I'm going to prepare myself mentally and physically to go on that journey. And I'd say that to anyone with or without COVID, because it can be quite a stressful time anyway. And of course, COVID will have disrupted so many systems, and there'll be anxiety and some level of health anxiety and anxiety about fertility and all of that. And we know the anxiety becomes part of the problem around conception anyway. So, just taking care of yourself from scratch at this point is something that should be on the list of things to do, because it will help with long COVID, and it will help with fertility, and it will help with just managing the whole journey, because it's not often as simple as we want it to be.
Yeah.
Tanya,
let me come to you for the last word on that bit.
No, I don't think I have much to add to that really, other than the question was phrased in that should she be worried about fertility if she's still having relapses with her menstruation? And I think it's a good sign that someone's fertile, that someone's ovulating, is if they're having regular periods. So if she's having a regular period, although maybe having relapses with her fatigue, that the fatigue element isn't really affecting her fertility. The fact that she's having a regular period means that she's most likely ovulating, therefore is most likely going to be fertile and get pregnant. So the relapses, although they're unpleasant and not very nice, they're not going to affect, or it's very unlikely they'll affect her fertility. So and I think what Claire says, just about trying to make sure you're as strong and healthy as you can be. There are women who are pregnant with long COVID on the group, and I think everyone's different. So some people feel a bit better when they get pregnant, some people feel worse. I think it's impossible to say.
Fantastic. Well, I think that's a really nice piece where you're saying actually the fact that your body is still doing periods is a really good sign.
Yeah, exactly.
But so I think hang on to that as a positive. If that's you and you're watching this, hang on to that. It's a positive, and it's just about making sure that you do the best that you can to get yourself ready to be able to go on that journey and enjoy it, rather than kind of drag yourself through it. So and I guess also just choosing the time, maybe if you're still experiencing quite extreme relapses around the period, maybe just give yourself a few more months before you're having this conversation with yourself about, now, should I go now? The body's very clever, and it will probably make that decision for you. Guys, I think we're at the end of our amazing list of questions. This has been absolutely fantastic. Is there anything that either of you would like to say, just maybe as a word of reassurance to the women listening, that maybe they can kind of take away from all of this? Is there anything? Claire, let me come to you. If there was one thing that you could say.
I'd say that, as with, there's still so much that's unknown about COVID and long COVID, but each day as health professionals, we're learning more, and each day there's more nuggets of information that are coming out that we can help you with. And I think that for all of us, knowing that we just don't know it at all is really important. But to still be having those conversations, to still be engaging with one another, and particularly still be engaging with your health professional about how you're feeling, no question is too small, no question is too silly, no question is too big. I think keeping engaged in those conversations are really important. And also knowing that there are long COVID clinics out there and being set up, and they're learning more as days go on. And so if you're feeling that you're stuck, or you're feeling kind of alone, speak to your GP or speak to your health professional about potentially getting a referral to a long COVID clinic, because they do exist and they are very holistic in their treatment. So it's not just about your physical symptoms, it's about treating your mental health too. And like you say, Susie, thinking about yoga, thinking about your breathing, thinking about mindfulness, all of those things will also benefit you. So there's lots that you can do.
Great. And Tanya, if someone has a doctor that they're really, really not getting support or help or understanding from, and I know that, you have been a long COVID patient, so I'm sure you've encountered or understand at least the frustrations that some people have, what would you say to them?
I think if you're talking to your GP or a doctor that you think doesn't understand you or doesn't believe in you, then absolutely ask for a second opinion or speak to somebody else. And hopefully you'll find another GP in that practice who will understand you and will be more sympathetic. But as a last resort, I suppose people could change GPs. But most of the time, you will find someone there either who understands, who has some knowledge about it, or who can empathise with you. And I myself have spoken to doctors who don't get it, and I've found some lovely doctors who really do. And so you just have to maybe shop around a little bit, unfortunately, if you find one that isn't helpful.
That's really great advice. Thank you once again, both of you, for your time, your wisdom, and your contribution to this really, really important conversation. Guys, if you're listening, make sure that you keep asking questions to the group, because, there are so many women now sharing their stories and their experience. And I think there's a lot of people who are much further down the line than some of the newer people coming in. And so there's now, you've got some kind of group elders who've been on the journey for a lot longer, who can sort of offer some support and advice. So, in the way that we're getting some great thoughts here, we can also learn from each other in the Facebook group. So keep asking questions and being curious about what's happening, because I think that really helps, educating ourselves around how our bodies work and why these things are happening is really empowering. So thanks once again to the both of you. It's been an absolute pleasure to have you with me, and maybe we'll come back again and do a number 2 at some point. I'm going to press stop now, and then I'll have a little chat with you in a minute. So I'll say goodbye.
Thank you. Bye.